I think the biggest unanswered question, obviously the biggest unanswered question is like, can this be used as a de-escalation maneuver? We don't know that for sure yet. I mean, this is a finding where we saw a surrogate endpoint that we sort of defined in this analysis. So this is for sure not a standard endpoint, but it's based on clinically meaningful data. So I think that the next step of something like this would be important to define which population we feel is maybe the safest to attempt de-escalation. I would suspect the lowest hanging fruit with that would probably be a patient who was, node positive, premenopausal, so they would likely be recommended for chemotherapy, but maybe they were low grade or, had low risk molecular testing or something like that. That would be, I think, a very low hanging fruit. Of course, you could attempt that, across the board, but I think it would be, potentially concerning to try and do that in patients with high-grade disease or a high oncotype or a high mammoprint or some other, high proliferative marker where we would tend to think of there being benefit of chemotherapy, probably be a riskier patient population to study that in.